I think also just kind of understanding the employers and what they're paying for these drugs. And I think that there's not a lot of visibility from employers a lot of times around how this category is broken down and perhaps how they may be overpaying for infusion drugs.
The industry as a whole, right? I mean, you're looking at via FDA approval. Once again, 10 years ago, we weren't even talking about this.
Hmm.
Today, it's a $150 billion cost driver in the healthcare system. When you are looking into the future, between now and 2030, the expectation is that anywhere from, depending on your source, you're looking at like 10 to 20 new drugs being approved that are infusion therapies specifically every year between now and then. We want to move the patient out of any high cost facility that's operating off of a margin on the drug, because even moving the patient from a hospital to a infusion center, say, you might be going from the hospital, which is marking up the price of the drug by 150%, to an infusion center, which is marking it up by 75%. You're still paying 75% too much for a really expensive drug, right?
Hello, everyone. Today I have Rob LaHayne with me, who is the CEO of Leap Health. Leap Health is a company that's operating in the specialty pharmacy and infusion care space. And we're going to talk today about the new specialty pharmacy cost and patient experience opportunities that are present for employers and how that's really shaping and changing the game. So welcome, Rob.
Thanks, Lindsay. Excited to be here.
Awesome. Well, do you mind giving everybody just a little bit of background on your experience and who you are and who Leap Health is to start things off?
Yeah, sure. So, Rob LaHayne, like you said, and I'm the co-founder and CEO of Leap Health. We work with large enterprise employers to identify high-cost claimants on specialty infusion drugs and move them into a more convenient site of care, most typically the home. And B, on the other side of it, we've created a cost savings program that actually dramatically reduces the amount of cost associated with specialty infusion therapies for large self-funded employers by creating a transparent pass-through model on the cost of the drug. So that's super high level. I'm sure we'll dig in more. My background, I've been in employee benefits for about 20 years, like a lot of people. Started on the carrier side, eventually made my way into benefits technology, and eventually became a consultant myself before starting a care navigation company that I built and led for about 4.5 years. Once we got done with that, I met my co-founders here at Leap Health, and we had an interest in going really deep in a really targeted way to help solve employers' cost problem, and really sort of double click down into specialty as an emerging cost category for large employers and for patients alike. And identified an opportunity here where I think that we've found a great way to sort of execute on what I always say is like the two goals and the sort of golden rule in employer healthcare, which is like, A, can I save you money? Yes, there's a huge opportunity to save money here. And B, can I make your employees happier and healthier and more viable? And the answer was a strong yes. So we had enough conviction around the product and sort of the opportunity here at Leap Health, and we decided to launch the business.
Yeah, that's super exciting. So yeah, I totally agree. I mean, specialty pharmacy is obviously a huge cost category and cost driver for employers. Everyone's of course always talking about it. Why did you guys decide to focus on infusion care and then maybe infusion, drugs in the home as kind of side of care? Like tell us a little bit about, what like really helped you identify that as kind of the key opportunity and where you want to focus Leap Health.
Yeah, specialty drugs as a category for employers has been an emerging cost driver for the better part of the last 5 to 7 years, right? I would go back further than that. It was about 10 years ago now. I was a consultant. We weren't even talking about this with our employer clients, right? So it's at least a relatively new emerging category for employers, but it's driving 40% of overall pharmacy spend and 10 to 15% of overall medical spend, which is being driven by 1 to 2% of the population that is on this category of or subcategory of specialty drugs, which are infused drugs, right? So drugs that need to be administered intravenously by a medical professional, not a self-injectable, not a pill, et cetera, right? We focused in on that area because I think there's the combination of patient experience, right? Once again, these patients need to go receive care And it can be a pretty, pretty undesirable experience as a lot of things in our current healthcare system. And then cost savings. And so specialty drugs as a category, the drugs tend to be expensive, right? So they drive a lot of cost. And as more specialty drugs hit the market and there's fewer alternatives from a biosimilar or a generic standpoint, that drives cost for employers because more and more patients are on specialty drugs. If you look at infusion as also a growing subcategory within specialty, there's an additional layer that drives cost, which is known as buy and bill margin, right? Most of the drugs that we work with in the infusion space, because they are professionally administered by a medical professional, like I said, they're actually covered under the medical benefit, not under the pharmacy benefit. So in most cases, they're reimbursed and negotiated the same way as any other healthcare service would be, right? So people have sort of gotten used to the idea that if you get your MRI done at the hospital, it's going to be a larger charge, a bigger charge against the plan than if I went across the street and got the same MRI on the same machine done at the imaging center. Specialty infusion drugs works the exact same way, right? The providers negotiate a reimbursement with the payer, which ultimately determines what that payer gets paid or that provider gets paid for administering the drug. And it's all a percentage of the cost of the drug. And so back to the initial point, like these drugs are expensive. Even a small markup or margin on that drug can drive a pretty significant amount of cost for an employer. When you're talking about drugs that are being administered 7, 8, 9, 10 plus times per year for a patient, and consistently cost 20, 30, $40,000 or more per dose, it adds up quickly.
Yeah, and I mean, obviously, I think of, drugs that are infused, and I think of oncology and cancer-related drugs. Can you give some more examples of the types of medicines that are oftentimes, actually infused or like delivered through infusion for patients?
Yeah. Yeah, I think everybody sort of reacts to that and thinks of oncology, and that is a big portion of the spend for a lot of folks. But when we talk about that savings opportunity, a lot of times we're not even talking about the oncology drugs, right? It's sort of its own category. We have cancer programs here at Leap Health that focus on oncology patients. We handle them a little bit differently, as you might expect. But a lot of the infusion therapies that are available today are for chronic conditions that we all sort of know somebody with, right? A lot of gastro type of conditions, Crohn's disease, colitis, a lot of dermatological issues, rheumatoid arthritis, neurological issues like multiple sclerosis. So, and then there's a whole category of rare diseases that tend to be less known, but super expensive to treat. And so, yeah, it's a pretty broad span when you think about infusion, which is part of what makes it so hard to track. I think we tend to be very condition based when we look at our spend as, sort of as a whole. Oh, we spent X amount on cancer last year, or we spent X amount on diabetes, et cetera. And infusion spend can kind of touch a lot of those different categories and maybe chip away at the spend on a lot of those different categories without you noticing, which I think makes it really unique.
Is the portion of drugs that, can be delivered, through infusion, is that growing just as, there are more complicated drugs coming on market and more of the rare disease types of medications and things like that? Like a lot of the categories that you mentioned, again, are things that, like you said, they're people that we, all know people that are working that have these types of conditions. So is that category growing as kind of a percentage of specialty pharmacy care?
Yeah, absolutely. So, the industry as a whole, right? I mean, you're looking at via FDA approval. Once again, 10 years ago, we weren't even talking about this.
Mhm.
Today, it's a $150 billion cost driver in the healthcare system. When you are looking into the future between now and 2030, the expectation is that anywhere from, depending on your source, you're looking at like 10 to 20 new drugs being approved that are infusion therapies specifically every year between now and then, right? So every year that 10 more drugs come out, 20 more drugs come out, you get more and more patients. So that 1% slowly creeps up to
Mhm.
2%, 3%, 4% of the population that are now on infusion drugs. And it's a great thing because, more specialized treatment, more advanced treatment is enabling people to live healthier, more viable, more comfortable lives. But at the same time, it's driving a lot of costs for, for employers or for payers who are ultimately the ones writing the check.
Yeah. So then back to your comment about, 10 years ago, employers weren't really talking about this. This wasn't so much on their radar. It's becoming a bigger problem for employers, over time as more of these drugs come on the market. I think that makes a lot of sense. We talked a little bit about rebates and like to dig into that a little bit further in a bit. But I think also just kind of understanding, the employers and what they're paying for these drugs. And I think that there's not a lot of visibility from employers a lot of times around, how this category is broken down and perhaps how they may be overpaying for infusion drugs. Can you talk a little bit about that?
Yeah, I think it can be confusing sometimes, partially because I think you're typically trained to think that your drugs are administered through your PBM and not your medical plan, right? And most of the drugs that we deal in are actually being billed through the medical plan. So first things first is you have to look at the medical plan for the claims, and you have to be able to sort of decipher through the codes that are billed for these drugs, which are typically referred to as J and Q code drugs, right? And then once again, sort of breaking down that categorization of, okay, condition-based assessment of cancer, diabetes, et cetera, and looking at it as a infusion spend as its own category, right? And so we sort of say, hey, what is your total infusion spend? That's going to cross multiple categories from a condition standpoint. And we can talk about which ones are safe to be administered in a different site of care outside of the hospital. And that's sort of step one. And then part of the reason why I think there's such a huge savings opportunity, part of the reason is over 50%, close to 60% of infusions are administered in the hospital today, right? So, and that's for no reason other than patients are just getting their infusion done in a hospital or an infusion center affiliated with a hospital, right? Most of these drugs, at least the roughly 200 or so that we deal in, are safe to be administered in an alternative site of care, whether it be an infusion center or in the home specifically, which is the predominant source of where we treat patients. And so step one is sort of identifying that J code spend. And then step two is identifying the strategy for reducing that spend. And I think where most folks who have taken steps to do that have relied on the health plans, right? Which misaligned incentives all over the place there. But the health plans typically will introduce a site of care or site of service program around moving patients out of high cost facilities into other facilities, right? The problem is, and for us is where we think that doesn't go far enough, is we want to move the patient out of any high cost facility that's operating off of a margin on the drug, because even moving the patient from a hospital to a infusion center, say, you might be going from the hospital, which is marking up the price of the drug by 150%, to an infusion center, which is marking it up by 75%. You're still paying 75% too much for a really expensive drug.
Expensive drugs, yeah.
So we want to move the patient into the lowest cost site of care, which we have created.
Yeah. And I think also, I mean, you mentioned obviously the patient experience. So, I just think if I'm a patient and having to go through, this type of care, getting this, having this happen in my home versus when it doesn't actually have to happen in the hospital or at an infusion care facility would be very appealing from a patient perspective. And then you also think about working age people who, maybe have a chronic condition. So they're still present and, working in their daily lives, and the ability to be able to do that work at home and have your care provided at home, I would think would really free up people. And, we talk a lot about productivity in the workplace, and, people value that at different levels, but I would think that would be, really a huge benefit from a patient experience perspective.
Yeah, absolutely. I mean, my team will give me a hard time when they see this because, it's part of my stump speech, but I use myself as the example all the time, right? Like I live in the lower Hudson Valley region of New York. My best option for infusion care is a hospital, which is a 25 to 30-minute drive away from my home, or I need to get on the train and come into the city. And so step one, that's super inconvenient for me, outside of any other outside factors. But I've got 3 little kids. My wife's an entrepreneur. I'm an entrepreneur. Like, doing that during working hours is extraordinarily disruptive to my work life and or my personal life, right? And so for somebody like me, a working person, which is the demographic that we work with, working through employers, it's, we're giving them a more convenient option. You can do this in your home. You don't have to travel. You could potentially be on a Zoom while you're receiving your infusion, right? And so, I think that the convenience play is really important to folks, and something that we emphasize pretty hard. When you think about like my parents, right? They're retired. They can go get their infusion care wherever they want, right? Like it's part of the adventure of the day for them. Whereas with working families, the convenience factor is really, really important, especially also in rural areas where folks are, I mean, we have patients that are traveling 90 plus minutes to go to get their infusion care every other week, right? And when they start working with us, they're thrilled because we're bringing the care into their home.
Yeah, no, that's hugely important. You talked a little bit about the carrier-driven programs or the health plan delivered programs. Can you talk about other infusion site of care options that an employer might have? So, as they're thinking about, infusion care right now, what does that world look like to them, and what are their options for how they can deliver this care to their employees?
Yeah, I think most of the options that exist today are predominantly driven by the health plans, right? So, some sort of a health plan site of care program, like I mentioned. Other site of care programs that exist outside of the health plan, there's PBMs, of course, who can administer these drugs in a formulary, but doing so usually requires some sort of a block. So it creates some friction for patients, which most employers don't really have an interest in getting their employees caught up in, right? You're moving the drug from the medical plan over to the formulary. It's going to reimburse that provider at a very different rate than it did before. And sometimes the provider is like, I'm not going to administer the infusion for that. So the patient gets caught in the middle of this and they need care. So those programs, while they exist, are less common, but more aggressive, if you will. And then, other site of care programs really just focus on sending patients to a more convenient site of care that is less cost than a hospital. So you can carve it out, you can leave it within the medical plan, bill it separately or not. But those are really the options that are available to folks, and to us, none of them go far enough because none of them eliminate that markup.
Right. That makes sense. That makes sense. You talked a little bit about J codes as well, and J code drugs, and we've talked a little bit about rebates and how all of that world works. But can you just unpack a bit more, how these drugs, have such significant markups on them, and like what again are some options for employers to bring that down, what they need to be asking for, perhaps from a transparency perspective, so that they can even evaluate what their options are to begin with?
Yeah. Yeah. I mean, it really depends on where the drug is covered or administered, right? So if it's in the PBM, PBMs are very good at negotiating rebates with the manufacturers, and I think more and more so are being pushed to share those rebates back with the plan in one way or another. So if you've taken the step to cover some of these drugs through your PBM, you should absolutely be working on rebates. That said, from a volume perspective, you're talking about such a small volume of patients comparatively to your more standard drug formulary, that the rebates just aren't as significant in the infusion space as they are on a typical drug. When they're administered through the medical plan, then it becomes a bit of a black hole, right? Like who's getting the rebate? Is it the provider? Is it the medical carrier? In most cases, it's probably the medical carrier. And so I think employers potentially have a little bit of an opportunity to push them on that. But once again, in terms of rebates on infusion drugs versus other specialty or non-specialty drugs, the rebate opportunity is just far less. And then even taking into account the rebate by removing the markup, the rebate concept is more like, hey, would you rather have your money now or later? Right? Like we're giving you your money now by getting you to the lowest price point possible and passing that directly through to the plan, versus relying on some sort of a rebate down the road.
Yeah. So then, if an employer, was looking to do something different and they wanted to work with the Leap Health, how does that work? If they have a traditional, program that is part of the medical plan that they want to carve out, like how does it work to start getting started with Leap Health?
Yeah, and so for Leap Health specifically, to give us a little bit of commercial, I mean, we integrate directly in with the existing framework of what the employer is doing, right? So That can take a little bit of time sometimes for us, right? Because we have to work directly with the insurance carrier that is administering the network and probably handling the claims on the ASO side. But it's even with a carrier led or a payer led site of care program, we're sort of an enhancement to that more than we are competitive in any way, right? We are just the lower cost option that employees should be going to if the goal is to move them to the lowest cost, most convenient, clinically sound, safe network. That's us. And so, typically what it requires for us is we want to be able to set up claims and prior authorization feeds so that we can do the work of identifying patients. And that requires cooperation from the medical plan typically. And then when we find those patients, we want to be able to work with those patients and send a bill to the plan, right? And
Mhm.
so the back end work is, hey, do we get coded in as a claim? Which codes are we going to use when we submit claims so we can track it back to LEAP and ultimately report back to the employer on sort of the impact that we had from a cost saving standpoint, but as least disruptive as we can possibly be for employers so that we can make it, truly easy to offer us as an option to their employees.
Yeah, I mean, I think that's smart. Obviously, employers are looking for low friction options. They have so many different vendors that they're already working with. So if they can, kind of bolt things onto their existing systems, I think that, that works much better. Is there a type of employer that you're seeing the most traction with? I know you mentioned jumbo employers. Obviously, I would guess that, they're looking for, more and more aggressive ways to tackle spend for their populations. And, they've obviously, already done a lot of the low hanging fruit. So infusion care may be something that's perhaps resonating more with them, but just curious if there's a type of employer or profile or geography or workforce demographics that
No,
you're seeing the most success with.
no, I guess is the short answer. Other than the number one driver of what we do is typically size, right? So you mentioned we work with jumbo employers, we tend to work with larger employers, right? 10,000 plus employees. That said, we also work with third party administrators and other aggregators of employers,
Mhm.
captive programs, et cetera, which brings our sort of reach down into that smaller market. And the reason why there's no sort of hard line in the sand in terms of where we work, but the reason why larger employers are typically the target that we work with is because at 1% of your population, you just might not have that many claims if you don't have that many people in the plan, right? So,
Mhm. Mhm.
so it really comes down to that. Like, is this a cost problem for you? Because of some of the dynamics that we've already talked about related to like this spans multiple categories. It's not just cancer. It's not
Mhm.
just gastro or just neurological or et cetera. Patient demographic tends to influence less what impact we can have, right? Because
Mhm.
industry agnostic, demographic agnostic, location agnostic, anybody, anywhere, any age could have Crohn's, right? Or
Mhm.
arthritis or a variety of other conditions that we treat. And so for us, it's more about finding employers who are looking to be creative with how they address spend, are
Mhm.
motivated by hard dollar cost savings, right? We are a true hard dollar cost savings solution in that we are directly influencing claims. I can show you what you were paying before. I can show you what we'd pay right now with Leap if we were the provider on that claim. And that's the savings, right? It's pretty simple. And so and are willing to take the step to, integrate us into their plan. Right. And those are really the big things that we're looking for and that's not what everybody's looking to do. So
Right. Right. I mean, it can, require some lift, but yeah, I think obviously the fact that you guys have those hard dollar savings and that you can very clearly articulate and show a very clear ROI on your services is obviously huge. So many solutions that employers may be looking at to address, different areas of spend or just overall, problems with their benefit plan are not necessarily going to have that hard dollar ROI. And of course, we're seeing more and more demand from employers for that. So that makes a lot of sense. When you're thinking, ahead, 5, 10 years, where do you think this space may be in terms of infusion care and, working with employers? Do you think you're going to have more employers, continuing to adopt and look at these types of solutions? And kind of where do you hope the space moves overall?
yeah, I think so. I think, in general, I see this space evolving like a lot of other spaces have sort of evolved in healthcare, more around like that kind of center of excellence concept. And I think with that, the idea of like how we define centers of excellence is starting to change a little bit in the employer space specifically, right? So sort of traditional COE model was more faced or more focused on getting folks into high performing academic medical centers or very highly specific centers for very specific types of cancer, surgeries, et cetera. And I think really what we're learning is the model here is, if you're thinking of a center of excellence, it's like, once again, getting back to how do we deliver care in the most convenient, comfortable setting for a patient, number one, because convenience in infusion care is actually related to the quality of the care, right? There's direct line to how convenient the care is for that patient to receive to how successful that treatment plan is because of adherence. If it's taking me 90 minutes to drive to my provider every other week and I got to sit in a waiting room and I've got to go through that, process of receiving my infusion in an impersonal setting that's, potentially with a nurse who's bouncing around between four patients, like that's a terrible patient experience. And if that's on my calendar tomorrow, like it's not something that the patient looks forward to, right? So we got to make it convenient. We got to make it comfortable for people to improve outcomes. And so I think that, the thinking around infusion and probably other categories into the future is like is centered around this concept of a center of excellence for patient care, which is patient convenience, patient satisfaction, making it easier to get care with high quality providers. And then cost savings, right? Like just a more transparent model. The big theme in sort of the PBM land is this one around like, all right, let's demystify all of this rebate stuff and discounts and things like that. And I'm just going to show you what we charge you for the drug, right? Like the Mark Cuban cost plus model. And I think that resonates with people. I think that benefits administrators, consultants, consumers are tired with like not having any idea how to navigate the system or what it costs or any of that, and then getting a bill and being, insanely confused. And the government's tired of it too, right? I mean, you're seeing
Yeah.
those changes happen left and right. So I think that that's sort of where this all heads. And I think, my goal over the next 5 to 10 years is to make this like a really prominent focus for folks is how do we shift the mindset of where patients receive care and line up quality with convenience so that people can be met where they are and actually receive great care, have great outcomes, and reduce cost in doing so. Right.
Yeah, I mean, I love that it's a win for the employer, it's a win for the patient. I mean, it's just a better way to solve this problem overall. And again, it sounds like it's going to be a growing area of concern for patients, for employers. More people are going to need these drugs. So I think that's just a fantastic vision for where things could go. Is there anything you'd like to share in closing, Rob?
No, I mean, I really appreciate being here and the opportunity. And for all the folks out there who are listening, we worked with Spark in the past and they did a fantastic job. So, I've gotten to know Lindsay and Anish and your team over the years, and it's a great team. So appreciate the opportunity.
Thanks, Rob. I appreciate that. Well, thanks so much for joining today. And thank you, everybody, for listening.